listening to The Doctor's Corner with Dr. Kline and Janelle Elgoway.
Good evening and welcome to the Doctor's Corner on CAW 360 Network. I'm your host, Janelle Elgoway, and I'm with the Donut King himself, Dr. Kline. How are you, Dr. Kline?
I'm just dandy, Janelle.
Great. If you have questions or comments for Dr. Kline tonight, please call in at 415-915-2291. You can also chat live with our audience on the YouTube channel Conspiracies Against Wellness live stream. So tonight we're going to be talking about addiction, or people that you know are addicted, chronic pain patients, and the current atmosphere we live in as patients and doctors within the United States. I also want to let everyone know CAW 360 Network will be launching here within a few weeks with a new website, several new hosts and shows, virtual online store, and an interactive database and library, and a blog. And in fact, Dr. Kline, you will be hosting a second show. We're still working on the name, but it involves 6 panelists with a virtual town hall theme and on addiction. Can you talk a little bit about that before we start taking call-ins this evening?
Now, what plan is this we have, Janelle?
About our town hall with the.
Yes.
Yeah,
we're going to try to have an open discussion about addiction. Now, why do we want to talk about addiction when the theme of the show has always been chronic pain?
Right.
The reason people are not getting enough medication, if at all, is because of the fear that something will happen to them. And what is the fear? That they'll become addicted. So addiction is very important to the 10 million people who are taking legitimate pain medicine versus the 1 million people who are taking opiates for yet another disease. And that brings me to a little announcement.
Okay.
The Massachusetts Supreme Court is currently hearing a case of a woman who was in rehab. She's a type B addicted person. That means she's a hardcore opiate addiction person.
Okay.
And she was on probation, and she failed one of her drug tests. So they jailed her because they had no openings in the rehab facilities. And so she had to go through an abrupt withdrawal for 6 days in the jail, where they provided basically no medical care. So an attorney in a small town outside of Boston, who was a social worker before, decided to file an appeal for this woman. And if you want to read about her, it was in the New York Times today. Mm-hmm. And what they are presenting before the Supreme Court is, if she has a disease, they should not be putting her in jail. And that if the disease involves high-frequency relapse, which it does, then just failing a drug test is cruel and unusual punishment. So it's a very interesting case. There are people arguing, for example, there's a Boston University professor who's written a book called Addiction, A Choice. So there are people that believe addiction is a choice, not me, but the other folks who believe it's a disease are going to get a chance to testify in a high-level legal proceeding. And I'll tell you something, courtrooms like that, before a Supreme Court of a state, they get to the truth. They don't mess around. You can't stand up there and make these outlandish statements. They want proof. And so there's lots of articles being submitted. So the stage is now set for a real, good, logical argument about whether or not addiction is truly a disease or its choice. If they rule that it's a disease, this is going to have a huge impact on people with pain disease. Because, wait a minute, if it's a disease, how do you create this disease? Can you just create this condition in anyone? It'll bring the topic to the center, which will really be nice. I have no idea how it's going to turn out, but I'm going to stay tuned in. And if you want to read about the case, New York Times today.
Okay, great. Thanks for saying about that, because I didn't even know. I haven't had a chance to check on. Also, have you seen anything about, is it Humans Rights Watch or Humans Watch Right? I forget the name of it.
Yeah, this is an international organization. It's human. I think it's Human Rights Watch.
Okay, sorry about that.
Anyway, they won the Nobel Prize, this group. I mean, this is a serious group. And they are in the United States right now looking at the issue of denied treatment. So I don't think they published their report yet, but I think there was a small side report published. Do you recall the title?
I don't recall the title, but I believe it was in either the New York Times or I think it was the New York Times, and it's going to be coming out on one of the mainstream media networks.
Okay, excellent.
Yeah, so it will be really interesting to watch because, I mean, that's huge. They were talking about, being in Sri Lanka, being in Afghanistan, and all of these, like, third world countries where you think of the worst of the worst, and then in the United States, they're talking about pain patients are being treated like the worst of the worst. So,
well, believe it or not, it's a United Nations basic right to have your pain relieved. Bingo. I mean, it's just there as an international right to treatment, not a right to treatment in general. This is specific. You have a right to have your pain relieved. And it's hard in many countries because of shortages and I don't know, cultural disbeliefs. I'm not quite sure why other countries have so little. We're lucky because we have kind of an unlimited supply. Of course, it's being turned around as a negative thing, that it causes addiction. But there again, is addiction a disease or a choice? Right.
And we're going to actually be talking about that tomorrow night, too. Dr. Steve Henson's going to be on. He was rated actually in the last, I believe, 2 years by the DEA, but he has I believe, a nonprofit that he goes all over the world, which he can't do now because they take your passport along with your DEA license and everything else. And there's been no account as to whether he's guilty or not yet, and he hasn't been in a law of court. But he's going to talk about all the different countries and what it's like over there. And I think it's interesting because we don't really get to hear a lot about that. We hear from mainstream media, but it always looks terrible. But actually, he's going to talk about that they get pretty, decent care when it comes to, pain patients and stuff. Like here, I mean, we're struggling here. Well, they struggle there. So it will be interesting to hear what he has to say about that more.
Yeah, I may tune in.
Sure.
It's more straightforward in other countries, but in our country, the whole problem of proper treatment of addiction, which is pretty crummy, rehab facilities are unregulated. They do what they want. They frequently have very aversive, you've got to hit bottom, before this is going to work. And they take people who have a serious disease and all the secondary problems that go along with addiction. You're stealing things and manipulating, and you just kind of feel awful. Right. I mean, these are not people without consciences. They feel terrible, and then they get into these rehab facilities that just pour it on and make them feel worse. Oh, we need to make a list of your sins and blah blah blah. So the way we approach addiction is based on moralist views, and that's carrying over into chronic pain patients, and it's carrying over into the general public. Right. And that's kind of why we wanted to have this forum tonight, to answer questions anonymously about any concerns or fears that people have about addiction, and then any questions from people who are addicted or have family members who are addicted. And we need to, and pain patients, we need to start bringing this to a point of understanding, the same understanding that we came to about people who are gay or lesbian and people with AIDS virus. These are things that 10 years ago were totally in the same position as addiction and the use of opiates is now. Right. That it's given this, it's demonized, really, morally demonized. That's the way it was with gay folks And then, of course, if you've got HIV, God was just punishing you.
Yeah.
So now we have, I don't know, I think we have gay presidents of countries, and, you know, it's just wonderful, you know, that we have stripped away the old New England moralistic view of life in general, which is you do what we tell you to do.
Yeah.
We want that to occur with the problem of opiates in general. So,
let me ask you, when you were in school and going to medical school, did you ever have any idea that this was going to happen with chronic pain patients? Like,
no, I didn't. And as a matter of fact, I've been doing this 40 years, and I still can't believe it's happened just in the last 2 years.
yeah.
This is going to go down in history as the worst medical disaster, healthcare disaster in the history of this country.
Yeah.
And right now, it's just nobody even kind of realizes that it's going on. But when you affect 6 million people, and that's a good figure, we've got good backing for that.
Mm-hmm.
When you take away medical treatment from 6 million people and cause them to suffer, it's just unimaginable. This is not like taking a cardiac medicine away because we're concerned about its dangers. This is taking people's functional lives away from them.
Yeah. Yeah, and people are killing themselves because of it, or they're dying, or they're living miserable lives. I was one not too long ago, and you know about that. I'll probably talk about it a little bit later. I do want to ask you, though, can you talk a little bit about, because we never get into, you know, everybody's so caught up in the opioid crisis, we forget about learning about what is dependence and addiction. And can you talk about what the difference is between that so people get a good understanding of that first?
If you take an antidepressant, you will suffer withdrawal symptoms when you stop it abruptly. If you're taking Valium or Ativan and you stop it suddenly, you will have withdrawal symptoms. If you're on an antipsychotic drug, 50% will have withdrawal symptoms. If you're on an opiate, you will have withdrawal symptoms. All of those have become dependent. That's a real bad word. What's happened is you have become biochemically integrated so that when you unintegrate and you stop taking the pill, you then have a body reaction. In other words, your biochemistry was depending, I hate to use the word, the biochemistry was utilizing the medicines in any of those groups. And when it got used to utilizing them and it set up new biochemistry, when you take it away, then the biochemistry has to readjust. That's dependence, and we need to stop using that word.
Okay. What
you know, and I just biochemically, either biochemically dependent, at least modifying it. I'm still searching for a good word, so if anyone in the audience has any ideas, to get away from the connotation of dependence.
Yeah, because it's very negative, you know, and we have to change it. And you always come up with great little taglines or little words for different things, so I hope somebody will or you will.
It should start with biochemical. You know, if I'm taking a diuretic because my feet are swollen, excuse me, let me get this off. Good grief. Earth life. Where was I? Yes.
Biochemical words.
Yes. Biochemically something. Because, so now your biochemistry has to readjust.
Mm-hmm.
And so in readjusting, your biochemistry says, I'm going to punish you, and you feel terrible. But that's got nothing to do with addiction. If you take 100 people and you give them all opiate pain medicine, in a month or so, pretty much all of them will become biochemically integrated so that if they stop, they're going to have withdrawal symptoms. There are a few that don't. You know, we hear occasionally of people just stopping their opiates, but everybody's biochemistry is different. You know, so it's just kind of general. I mean, we doctors talk in generalities because there's no such thing in medicine as 100%.
Right.
And, you know, you have to work within parameters. You have to, you know, be flexible. So addiction is different That has got nothing to do with dependence.
We do have somebody from YouTube saying biochemical expectation.
Oh, I like that. Yes, that's excellent. Yeah.
And somebody else is mentioning that their son is 36 and an addict in a private doctor program and is treated like a king, but they can't get their pain addressed. Tell me why. They're asking why is that. People want to know too.
Yeah, let's see if I can turn this thing off. Let's see, it's button up here on the left.
That's tough.
There we go. Okay. What was the question?
Okay, so a woman has a 36-year-old son that is an addict in a private doctor program and is treated like a king, but they can't get their pain addressed.
Okay. Why? Because for good reason, if a person is in a steady state, getting just the right amount of opiates, if that young man is getting opiates, to give more opiates will trigger more of an addiction, and that's true. Mm-hmm. But it has to do with access. In other words, serious addiction B, where you have a brain change, is also an addiction A, which is behavioral. So if the person is given a regulated amount of pain medicine, they will be fine. But if they're allowed to get their hands into the pile, that's the behavioral part. The behavioral part is seeking and finding. So the payoff is like an Easter egg hunt, right?
Yeah.
So the payoff is finding the Easter egg. So the behavioral part of B addiction, or serious junkie addiction, as folks in the street call it, what you do is you have somebody else give the medicines.
Okay.
A trusted person gives the pain medicines and then takes the bottle away and hides it.
Didn't you mention also that there was like a machine that you...
There's also a machine. They're about $800.
Mm-hmm.
It's like a little round tank, built like a tank. And the pharmacist loads the pills into it, and it will dispense out into a little dish the pills on whatever schedule you want. So out come 2 Vicodin tablets every 4 hours. And although I heard a story from an addicted person who said, yeah, I had a friend of mine who took a big sledgehammer to the thing and got the pills out. So, you do have to supervise it. Mm-hmm. But there are ways, and people who have addiction disease have the right to be treated for their pain just like anyone else.
Right.
Deciding not to treat somebody for any disease is a very serious medical decision. So deciding not to treat somebody for their pain, no matter what their circumstance is a serious decision.
Yeah. Well, I get always asked, and people always want me to ask you why, if they're a chronic pain patient or that, like, why they're not being treated that way. And why did they clump everybody together? It seemed, at least in the beginning, addicts and chronic pain patients.
I just found out the other day it did not start with the Harrison Act in 1915. It started in 1909. In 1909, the U.S. government passed the first restrictive law banning opiates from certain uses, and did not make it a crime for doctors to prescribe. But 6 years later, the Harrison Act, even though it didn't say so, was interpreted that you could go arrest a doctor for treating an addict. Now, why is that? I mean, why would you arrest a physician for treating an addict? You don't arrest physicians for treating anything else.
Right.
It was because it was believed that the opiates caused immoral behavior.
Right.
And that's what started it in 1909 when they passed this opiate law. That's when
before Aslinger was his name, or? Yeah,
Aslinger started in 1930.
Okay.
So this is way before good old Henry. So this actually started the epidemic we see today. The epidemic is basically heroin addicts dying because they don't have access to medical care. And it started in 1909 because they made it so hard to get opiates. People went to the streets. So they started going to the streets in 1909, and it hasn't changed one iota since. So the answer to the question is, why are these particular drugs being culled out of the group? It's because of the immorality that they cause. And the immorality was sexual. Mm-hmm. This caused white women to run off with foreigners and turn into prostitutes. And if you talk to anybody, who's in the addiction area, nobody's even interested in sex. I mean, this takes your sex drive away. Mm-hmm. Opiates, the other drugs, marijuana and stuff, different story. But so the characterization of this drug is pretty much the same characterization, moral characterization, that the school teacher in the Scarlet Letter received when she had an affair. Mm-hmm. So it's the same moral thing. It's always seems to be sexually oriented. The stories that Anslinger, his name was, Henry Anslinger, told in the 1930s was always about two Negroes taking a white woman off for, they weren't going to kill her or rob her. They were going to have sex with her.
Well, that
was the crime.
Right, and also sickle cell, right? They said it about that, too. And within South America, that people would come over, and when you would have a mixed baby or something?
I'm not familiar with that. Go ahead, tell the story.
I know Nita Thompson was on a few months ago, and she mentioned that it's actually just a myth. But, originally when foreigners would come over and they come through South America up into, like, California and stuff like that, they were saying that sickle cell was predominantly only with black people or, African American or just not from white and American and, United States American. And if you had a baby and it was mixed at all, they automatically thought that if you got, if the baby had sickle cell, that's why. But they didn't, and also if they looked white too, because white people, it's actually a myth, but white people can get sickle cell too, just like
yes, that's true.
So that was just interesting.
Mm-hmm. It's all about morality, It's funny. It's always been a joke in our family that we blame everything on the Puritans.
Right.
But they really were awful people. They hung Quakers. If you didn't toe the mark, you were banned, which is a terrible thing to do. You ban people and then you shun them. But they actually hanged people, because of religious differences. So wow. This is the reason we have separation of church and state. The framers of the Constitution said, look, we're not going to have any more of this. Even in Massachusetts today, the legislature is called the Massachusetts Court.
Really?
Because back then, the religious folks ran the legislature and the court. See, it was tied up. No separation of religion and state. So the Massachusetts Court is left over from that. Of course, it's an independent legislature now. Mm-hmm.
Also, I wanted to know, because I asked you a little bit ago if you had any idea when you were in medical school if this was going to happen. But people are asking, why are they getting turned away from their doctors, or why are they, going with the 90 MMEs, even though the CDC came out and said that that the overdoses and the people that have died are actually incorrect stats. But they want to know, is it from the fear and the myths and the lies, or what's going on? Why doctors?
Combination. Physicians really are poorly trained in pain. I never had officially a pain course. I just kind of learned it on the job, apprentice stuff. But there's always been this thing, and including me when I was growing up, that people with pain are faking it and they're just trying to get drugs.
Yeah.
And that's really awful. That's not what it is. And so my Twitter stream, has helped me to understand by hearing from people with these rare diseases, because in my own practice, I've only had a few. And most doctors don't know what a lot of these diseases even are. So we need more. We need post educational about rare diseases, and we need for doctors to hear and see in print stories from patients, and to try to learn to change this terrible prejudice that we have against people in pain. It's really, the CDC has brought this out. Mm-hmm. I mean, doctors are not even treating people in emergency rooms. There's a hospital in south of Boston, proudly announced it wasn't giving out pain medicine anymore. Wow. You know, this is insane. This thing has gone over the cliff. It's, you know, medical schools now, the CDC is running around with their tainted educational sessions in medical schools. And this is really scary. You know, I mean, you tend to carry away from medical school beliefs, you know, that are very difficult to change later. So, you know, it's very important that people keep speaking up and letting doctors know, you know, that this is not the case, and having intelligent, you know, adult conversations with doctors. You know, doctor, I'm sorry, you know, from my standpoint, I think you got it wrong, you know.
Right. We do have a caller. Caller, welcome to the Doctor's Corner. What's your question for Dr. Kline?
My question is, how do you get rid of hepatitis?
Depends on the hepatitis. Hepatitis A, which is the kind you get at the hamburger joint when people don't wash their hands. Hepatitis B you get from sexual contact, or if you're a sewage worker, you have to be in contact with the stool. And hepatitis C is the latest one, and this is the one that's transmitted through needles. So those folks who are using needles for addiction disease are at risk of giving each other hepatitis C. There is a treatment for hepatitis C. It's $100,000 a year. But there is a treatment. There's no treatment for the other two. So if you have hepatitis C, you can get rid of it if you can get somebody to fund it.
Okay. We have another caller. Welcome to the Doctor's Corner. What's your question for Dr. Kline tonight? Hello?
Hi, Dr. Kline. My question was really, how can we fight against all of these regulations against getting pain medication? I suffer from pretty bad rheumatoid arthritis and back problems. I've been on over 90 MME for a while, and now I'm being forced down. But, you know, I know that there are groups out there, but just any advice you have would be helpful.
The best thing is the truth. And I have written a piece that you can find on thomasklinemd.com, and it's the HOURY, H-O-U-R-Y piece. 90 milligram cutoff does not apply to chronic pain. I've just gone through the CDC regulations. Are very hard to go through. I've been working on it for months now, a little at a time. There is, based on my review, there is nothing in the CDC regulations requiring tapering or suggesting a 90 milligram cutoff for anything other than the very first dose. There's nothing in there. I just got a letter from some insurance company, who's looking over my prescriptions. Doctor, you're not, this 90 milligram thing, you got patients over 90 milligrams. So I just wrote the medical director a letter and said, I got out the CDC regulations, which anybody can get, by the way, on the internet. You just plug in CDC guideline. And I said, I can't find it anywhere that there is a valid 90 milligram cutoff. They recommend it for first time, and they recommend it within the body for first time. There's nothing in there about restricting long-term use. So what you can do is do the research yourself, and I'm going to be putting more articles up about the fact I can't really find any justification. What it boils down to is the 90 milligram cutoff was made up. by the people who were hired by CDC, who met in secret, and they made it up. And they pretty much admit that by saying we have no scientific evidence. And then they use a cute little phrase called contextual evidence review. Now, this is a phrase I never heard. I just thought I was an idiot. So I wrote a couple of physicians at the medical school who were into, research and papers. I said, have you heard of this? Nope. Never heard of it. So they made up this term, contextual evidence review, which means you got a bunch of people sitting around a table giving their opinions. So the CDC met in secret, and Congress got after them for that, and they decided on this 90 milligram cutoff after the FDA already said, hey, according to what you submitted to us, as many people die below 90 milligrams as above. So the myth has been carried forward, and you can start challenging the doctor. The other thing is most states have very few regulations, and all you got to do is in your own state, like I'm in North Carolina, I just Google North Carolina opiate laws or opioid laws, and you read them, and lo and behold, there aren't that many. And they certainly do not apply to chronic pain. As a matter of fact, if you read them very carefully in other states, chronic pain is mentioned as not being applicable.
Well, we have a question. Somebody wanted to know, the control of opioids and marijuana, is that an extension of prohibition? And did we not learn from it?
Well, it absolutely is. It was Henry Anslinger, our 32-year drug czar, that got it made illegal when most states didn't want to do it, and he had to twist their arms to get them to agree to making it illegal. It was Henry Anslinger's fault, because when Henry Anslinger talked about dope and Negroes running off with white teenagers, he was talking about dope, and in his mind, marijuana was the dope, then cocaine, and then opiates. So he kind of lumped them all together and created this immorality of all drugs. When you read government reports, it says misuse of drugs.
Yeah.
And abuse. Now, abuse is a moralistic term. We used to say that people had drug problems. That's a much better way of saying than what the government now is saying. People have an opioid use disorder. Right. That's the new term for addiction, and they're wrong, because the definition they're using does not fit type B or even type A addiction. It doesn't fit anything. They've just made it up. But you see how the moralistic terms are creeping back.
Right. Yeah. We do have another caller. Caller, welcome to the doctor's corner. What's your question for Dr. Kline?
Hi. Actually, it's not a question. It's a comment. Dr. Kline, hi. This is Linda Cheek. I wanted to comment on your earlier thing about teaching in medical school. And yes, most of the doctors out there have not been taught proper pain management. I know in my training, which happened in the late 80s, early 90s, the closest I got to being taught pain medicine was take a few Percocet after surgery, and that was it. Discharge them, with a handful of Percocet and it'd be done. But those of us that are actually interested in pain management, such as I learned it and became interested in it when I also was faced with, like you mentioned, the fear of doctors having not been taught about pain medicine, that a person coming in saying, oh, my back, I have a back pain from a motor vehicle accident that I had 10 years ago, and we would think that can't be possible. That should have healed. But what I learned through alternative medicine is that we don't heal anything in conventional medicine. And so these injuries from years ago do continue in the body because they've been untreated, they've been left untreated, and the pain is the body's expression of something's wrong. So, those things are things, those problems are things we need to change, and yet doctors are being put in prison for not having been taught proper pain management. And so
that's because you're liable just to addict the entire population, because the myth that's really behind this is that if you use high dosages, you're going to cause addiction. And guess what? That's not true. And I'm going to be publishing a little thing on my Medium to justify that. But that's probably the biggest error that we've made, as you pointed out, is one, not listening to people, believing that we know everything there is to know about medicine, which has never occurred in the history of medicine. And the one thing we don't understand now is chronic inflammation, chronic pain from these weird diseases. Somebody falls off a skateboard, and all of a sudden they've got this, complex regional pain. So I definitely agree with you. I think we need to, as professionals, get together with patients and write manuals. Here's the medicine, and here's what it's like to have this disease. So anybody that wants to help me, let me know, because, just getting down to the donut store is becoming a great problem for me.
Getting down to the donut store. Now, you did mean that as a joke, didn't you?
Yes. Well, it's sort of a joke, Linda. Sort of a joke. Yes.
Okay. Thank you.
Thanks for calling.
Thank you.
Is there a gene that causes someone to become addicted, and not only to opiates, but any drug or an alcohol addiction? Or is this a way that people are trying to cope with life?
It's both. Coping with life is addiction A. That's choice addiction. That means you go out and say, can I, you got any marijuana for sale, because I'm really feeling terrible, and it makes me feel better. And guess what? It does make you feel better. Versus a person with addiction B, which they try a little marijuana like everybody else to feel better, and then there's some Percocets on the table, and they take one of those, and oh my God. As in the New York Times article I was talking about, this person who has addiction since 14 says, "Man, I love this stuff." So that's addiction B. That's that's a brain thing. It is not choice. It's accidental, and we need to understand the two are different. Okay. You can have A and B, but you can't have A with B. The addiction A is all by itself, but you can have both if you have the receptor disease.
Okay, so what amount of addicts actually become chronic pain patients? Are there any statistics on this? And how do they get pain management then if they have any health issues?
Yeah, good question. Addiction is a genetic disease that runs across all strata. I mean, they're always doing these studies, that, they had this when they were younger. And what they're saying is the million people that have serious addiction, opiate addiction disease, addiction B, are a cross-section of the population. So presumably they're going to have the same number of weird, inflammatory, painful diseases. They're going to have the same number of failed back syndromes, failed surgery. They're going to have the same number of weird reactions that everybody else has, is well known in the painful disease community. So it's going to occur, and it's very difficult to get anybody to agree to treat them. And there is some concern, as I mentioned before. You got to do it properly, but they should be treated just like anybody else.
The other thing, we have a ton of people mentioning it right now, and I wanted to ask you too. And I don't get this way either. I've never gotten like that high that you're talking about, and a lot of chronic pain patients haven't either that don't have an addiction issue. So why is that? What's going on there?
It's just kind of a fact that if you don't have the genes, you're not going to get high. Now, this is kind of a new idea. Basically, if you take 100 people and you give them, and they all smoke marijuana, most are going to feel good. If you give the same 100 cocaine, they're going to feel good. If you give them amphetamines, they're going to feel good. Now, we can call those highs. You get high. If you take the same 100 people and give them all opiates, none of them are going to get high except the one person with the genes. So it's kind of weird that we believe that people go out and take opiates because they get high. Actually, you don't. When people take opiates, just like you mentioned, and just like 10 million people in this country, it just makes you feel relaxed, or it relieves your pain and you feel relaxed, or you become addicted to the idea of having your pain relieved, but you don't get the super highs. You don't get a high, you taking some or me taking some. We're not going to get highs even coming close to the highs people get with marijuana and cocaine and ecstasy and amphetamines. Everybody's going to get high from that stuff. So this is the wrong message.
Yeah.
The belief that we don't, and you hear it all the time, you know, that if you give people opiates, they're all going to get high and become addicted and start, ranging the streets in the communities, raping and pillaging. But curiously, it's not true at all. And, you know, I hear this over and over again on Twitter from the chronic pain patients. I don't get high. Well, yeah, that's true. The only people that are going to get high are the rare people with the addiction gene, and they will get very high.
Mm-hmm. Divine Simon asks, if a blood alcohol level of 300 mg/dl is lethal, how can medicine explain those patients that walk around among us with back of 700 mg/dl, sorry.
Of opiates?
Yeah.
Comparing the opiates, yes. You can overdose on opiates, and people take their lives, overdosing on opiates, but you have to take a whole bunch at once. Mm. If you're taking it on a gradual basis, like people who are heroin addicts, I mean, they have these enormous doses, but it's gradually you build up to it, and you develop this a steady state, it's called, or tolerance, another bad word, but you build a steady state where your body is it's like a bathtub with a cork out of the bottom with a cover off, so you're filling it up and it's draining at the same time. Mm-hmm. Well, this happens with heroin, folks. Your body is getting rid of it faster and faster, so your blood level's dropping, so you need more and more, and that's called tolerance. And it is kind of peculiar to the opiate medicine group that this happens. It happens a little bit in other things too. People, when they take Valium or Ativan, will find the relaxation they're getting from it is a little less. But it's very funny with opiates. It happens to a lot of people. And people on pain medicine need to have upward adjustments. And this is seen by the opioid fanatics, opioid avoidance fanatics, that it means you're addicted if you need more. That's not true. Mm-hmm. Just because heroin addicts need more doesn't mean that a person taking, medicinal opiates and needs a little more because their body's getting rid of it. That doesn't mean they're addicts. The science and logic of all this is real seriously wrong.
Well, we have another question. Why is there not more movement on adding a deterrent to opiates to prevent misuse?
Being Socratic, I would have to say, why would we want to do that? So if you make things harder to get for addicts, what happens? Do you think they're just going to say, oh, wow, this stuff's really hard to get, so I'm just going to stop? It's just a matter of choice.
You know what I was always thinking about, and maybe you could explain this a little bit better. So there's about 2 million, a little bit above or below, Americans that have an addiction, correct, in the United States?
Yeah, it's about half that, but it doesn't matter.
Yeah, I mean, it's hard to find the actual stats. Right. But, okay, so if there's that many, but we have, what, is it
320?
Well, how many chronic pain patients are out there? I know, like, the chronic pain, but the real, like, intractable pain patients, like palliative care. Why are we putting so much attention towards 2 million? Is it because of how much how many resources it takes from the United States? I have nenever understood this.
Because we're afraid of them.
Okay.
That's what's behind it.
What are we so afraid of? Are we afraid
We're afraid of dope fiends. These people are dangerous, immoral people that lose control and cause serious, break into people's homes, rape them, drag them off. See, that's why I wanted to have people ask questions like, is it true that addicted people have high crime rates? Is it true they drag people off? And is it true they're rapists? And so those are the kinds of things that I was wondering if run through people's minds. I'm not sure. But it's that stigma that's put on a medicine we've been using for 50 centuries that's very safe and does not cause serious crime. It causes a lot of stealing in the jewelry store, shoplifting, manipulating doctors, manipulating families, becoming con artists. But, you know, if you just gave them the heroin like they do in the UK, like they do in Switzerland, like they do in Portugal, then there's no more crime. It just stops.
Right. What about Suboxone? Because a lot of people are asking about that. Now, there's Narcan in Suboxone. My question is say if I was on Suboxone and I had an emergency and say I broke my arm and I have to go to the hospital, if they gave me opiates to help with the pain, wouldn't that counteract that and I wouldn't actually get help from that? Wouldn't that hurt me in a way?
Suboxone is a complex issue, and I'm not real sharp on it yet. I'm still looking into things, but basically Suboxone is a narcotic.
Right.
It's an opiate. And by the way, narcotic really is the best word because it covers all painkillers. You know, like fentanyl is not an opioid and methadone is not an opioid. So all this confusing stuff that comes out of the CDC about, oh, you know, they died from this, but not this because this isn't in the group. We just use the word narcotic. Covers it all. These are drugs that affect the receptors in your brain, you know, the endorphin receptors. The Suboxone supposedly is already like a little bit like Narcan.
Okay.
It does both. It stimulates the receptors, so it relieves pain, and in people with addiction disease, it takes care of the deficit they have in their own opioids. For example, an addicted person can take just the right amount of Suboxone. Nobody knows, including them, they're taking it. Perfectly safe to drive, they're functioning. They're just putting something back in your body. Like if you have a low thyroid, you take thyroid hormone. And it's kind of like addiction disease. You have a relatively low level of endorphin, so you're kind of putting it back. If you, Suboxone is sold on the streets. So when anything is sold on the streets, it means it's good stuff.
Yeah, I heard it's the number one abused medicine traded medication in prison right now too.
Yeah, it's hot stuff. But it can be used for pain, and it's a very effective painkiller because it's a narcotic, right? So it can work. As a matter of fact, you know, folks with addiction disease that need opiate replacement could just take a whole bunch of Percocets. It would work just as well. It doesn't have to be Suboxone. It doesn't have to be methadone. It could be anything.
Why is Dr. Andrew Kline pushing Suboxone so much and propping all of them? Like, what's with Suboxone? Is it they have a financial gain, or why can't we take a Percocet instead?
Well, nobody's really thinking that line. You know, the problem with medicine is we don't just think willy-nilly. You know, we try to stay close to the book. That's probably a good idea. We shouldn't be totally out to lunch. Dr. Kline, I think, believes this medicine works because it does work. Right. I think that's a genuine thing. I think he's worked with it enough to know that it's very effective. And when you hear stories of people both in pain and people who have addiction disease, it's a wonder drug, according to them.
I have a family member that's taking it. They just got out of rehab a year ago, and they love it. They said because they shattered their foot 2 years ago, so their foot's all messed up. But you know, it's helping with their addiction, and it's helping with the pain as well.
So it's an effective narcotic. You know.
So why isn't it good for chronic pain patients?
It is. It could be used. The price is kind of high. It's about $500 a month, and the federal drug police have a hand in it too. I don't know if you need a special license to use it.
They do.
Yeah, and it's like I can prescribe methadone for pain, but I can't give it to an addict or I'll be arrested. So I need to have a license from the government. to give it to a person with addiction disease. But as far as what I'm hearing anecdotally, without really researching the topic thoroughly, it appears to be a pretty good drug. And even though $500 a month's a lot of money, I mean, fentanyl patches are $1,000.
Right.
So,
someone asked on Facebook, YouTube, I was forced to buy Narcan because I still get 0.7987 milligrams per day. Is that a high dose? I'm not getting any relief. I'm wondering if they're getting it for pain.
Yeah, milligrams of what? Presumably an opiate?
Narcan. They were forced to buy Narcan because...
they're taking low-dose Narcan?
Yeah. And they're
low-dose Narcan is not approved by the FDA.
Okay.
It's kind of experimental. I'm kind of following the studies, and I don't really have an opinion yet. Okay. But using very low-dose Narcan, it's certainly...
Is it Narcan or naloxone?
Oh, I see. The two are related. Narcan is the stuff you sniff up your nose or get injected when you overdose. Okay. Naloxone is the same drug, but it's put into a pill. And the pill clogs up your receptors in your brain so that if you take an opiate, nothing happens. If you take a drink alcohol, nothing happens. It tastes good, but nothing happens.
Right.
So it's blocking the receptor that is causing the problem. Right now, my impression is that naloxone pills are great for taken once a day, are great for true receptor alcoholism, and that's the type of alcoholism where you have to have a continuous supply all the time, 24 hours a day. For addicts, it's not gone over real well. And I don't know why. I need to talk to more addicted folks to find out who've taken this. But I was in communication with a prison doctor up in New York who knew the addiction scene real well, and she said that the folks really don't like it, who have severe addiction disease. But for alcoholism, it's great.
Okay. We do have another call. Welcome to the Doctor's Corner. What's your question for Dr. Kline?
Hi. I have a question for you, doctor. Today I went to the doctor, and my pain doctor. I've had RSD for 30 years. He has harshly brought me down on the amount of medications that I'm on over the last few months. And today he actually gave the number 120 milliequivalents, but he's aiming for 90 with me because the mu receptor sites in the brain no longer take any opioids above that amount, he was trying to tell me. And so it doesn't work on chronic pain at all. Once you've been on opioids for the extended period of time, they're no longer effective unless they're in small doses. And I was wondering if you could talk about that, please.
It's kind of garlic bag science, hang a garlic bag around your neck. That's not true. You need to, I think everybody needs to start, when doctors hand you this line, is say, doctor, we're all good on the internet. Could you tell me where I can go on the internet and find out about this 90 milligram thing or the receptors don't take it? And if they say they've been to a conference, find out who it was at the conference who was giving them this. This is not true. This is made up.
I had asked him, and he said that all the studies in the last 20 years have proved this to be true.
Oh,
and
good.
I said,
well,
so
just say,
it's
doctor,
proven. Go ahead.
Yeah. Show me the studies, doctor. Here, get out your notepad.
Who is it from? Like the FDA? Where did they prove this? Did they say?
He did not prove it to me. He just said, you're arguing with the wrong person. And I said, so it happens to be the same amount that the FDA is suggesting, or I shouldn't say the FDA, and he said, the FDA was used. And then he said, they don't just pull these numbers out of their butt, quote unquote. To which
actually,
I said,
they
do. So, it's very hard. And I will tell you this, because I've been reduced so harshly, I have full body in my organs, it is very difficult to have a conversation calmly and the way that I would say, if I were medicated and I didn't have excruciating intractable pain throughout my body and organs. while I'm talking to the person who's holding the prescription in their hand. So
yeah, you need to say, you need to stand up and say, doctor, I think what you're doing is unethical. And I've read on the internet a lot, and I've talked to other doctors, and they don't agree with you. So I think what you're doing to me is purposefully harmful. And I no longer wish to be in your practice, and I'm going to file a complaint with the medical board, and I'm going to talk to my lawyer about undertreatment. Now, it's hard to do when that person is doling out the last little bit of medicine to you. But you can try to find other doctors. You just talk to people. One of the things I'm suggesting is to write up your medical history in bullet points. When I was in good health until I was 32. Then I started to have rheumatoid arthritis. As a result of that, here's what's happened to me. And you talk about your functional loss. And then you can say, I was put on medication 10 years ago, and it changed my life. I was able to do this and do that. I never showed any signs of addiction. I never got high on them. And you just write this all down, bullet point, bullet point, bullet point. And you send it to doctors where you're trying to sell yourself as a patient. And you say in the letter, you put a little cover letter on it, you say, I'm looking for a new doctor. I've heard good things about you, always do a little brown nosing. I've heard good things about you, and I need total care. I have a lot of other problems besides my brand X disease, and yes, I do take opiates, and I'm not addicted to it, and I've never had any problems with it. And then you it's called a pitch. It's like when you make a pitch to a publisher about a book. So it's a little short summary, and you send this around. If you call up other doctors cold, and say, I have pain, I need pain medicine, click. And try not to use the word pain if you can. Use the word discomfort and then loss of function. When my disease is flaring, and always talk about your disease, when my rheumatoid arthritis is flaring up or whatever, this is what happens to me. I spend 3 days in bed and I can't go to the store. I don't want to have sex. I don't want to play with my children or my grandchildren. I don't want to go to church or the shul. Kind of paint the functional picture. Doctors are afraid when people come in and they say, doctor, I'm in pain and I need Percocet. That is just, you're never going to get anywhere with that approach. So it's a drastic thing you have to do, but you have to kind of sell yourself. You have to pitch to doctors, and you just send them around to the various offices. Don't call first, because if you get a no, then you're stuck. Never ask a question if you think you're going to get no as an answer. That's like parents. Don't ask kids questions if they can just say no.
Right.
So, that's what you got to do. Putting up with people that are torturing you, it's really hard when they have you over a barrel and they're doling out these medicines, but especially if you get the scent, they're going to cut you even more, like cutting you back to 90 milligrams. Yeah. There's no evidence, I can tell you this, there is no evidence in the CDC guidelines that recommend tapering. As a matter of fact, there's even a section that says you need to be careful tapering people because they're liable to go to their lawyers.
Oh, wow.
Yeah.
Caller, did you take in any information with you at all, or bring up anything like this?
No, but I had brought his Dr. Kline's Palliative Care Act to him in the past. I do go in every 3 months for ketamine. This doctor knows me well. He knows the doctor that had me for 10 years prior to him taking care of me. But all in all, I just think he is driven by the fear of what's happening to other doctors right now, and that's overriding everything.
Yeah. He may be working for somebody, too, is telling him what to do. And, if he uses that as an excuse, say, doctor, I'm really not interested in being your patient.
Yeah.
If you're going to be listening to people up in the corner office instead of your own professional ethics, then I don't want to be your patient. And doctors don't want to lose patients. They really don't. It's a humiliating thing, but it's time that happens when they're behaving in a destructive manner. I'm sorry, lowering you on purpose is destructive.
We have questions about gabapentin, too. Can you address the off-labeling prescribing of gabapentin, Lyrica, and amitriptyline? I can't say it. Amitriptyline. Sorry.
These are anticonvulsants, and the worst thing the CDC did was to say that pain medicine should not be used first. That's a prerogative they did not have. Mm-hmm. They are not a regulatory agency in the field of prescription drugs. They are way out of line to say something like that. So now people are taking these horrible drugs. You ask any pharmacist about Lyrica, which is heavily promoted, billions of dollars a year. It's one of the worst drugs on the market. Yeah. And so it's given to people because a few people with peripheral neuropathy, that's that kind of stinging, right, numb pain that diabetics get and other people get, it sometimes works for that. It doesn't work for anything else. So why are doctors doing this? You know, they're substituting a drug that's not approved by the FDA for pain for a drug that is approved. All opiates are approved by the FDA. Lyrica, gabapentin, none of those are approved. According to polls that we did, it rarely works, and it has tons of side effects. If somebody offered me gabapentin or Lyrica for pain, I would say, no, thank you. I've been reading too much on the internet that it doesn't work, and it has horrible side effects. So why would you even suggest I take this when there's really a much safer drug, the opiates, that has less side effects, and we know it works?
We have another question. Dropping pain meds resulting in high blood pressure and ultimate double heart attack. Dr. Kline, do you think this medicine reduction can cause this?
Yes. As a matter of fact, I'm just reviewing for possible publications. Yeah, I got a lot of things on the list I need to do. Mm-hmm. No, it looks like I just treated a fellow recently who was an opioid refugee. His blood pressure was 160 to 165 for a year that he was in pain, and we just started him on some low-dose oxycodone. Mm-hmm. And within 2 weeks, his blood pressure is now 130, wow, and it's staying that way. So hypertension is definitely a side effect of pain. Heart attacks can be related to the hypertension. Mm-hmm. I mean, we consider hypertension to be one of the foremost health problems today. Yeah. And then we've got somebody with it. And the treatment for hypertension secondary to any other disease is to treat the underlying disease. Right. If you have hypertension because your thyroid is overactive, you treat the thyroid. So if you have hypertension from pain, you treat the pain. Right. There's lots of other reasons to treat the pain. And one of them is high blood pressure, and the other is suicide prevention.
Oh, okay. We have another question. Dr. Kline, can you address tramadol, which metabolizes into morphine and venlafaxine? I can't say it, in variable proportions? Sorry.
I don't know a lot about tramadol because I don't use it. It's a weird kind of drug.
I know it sounds good on your kidneys, or is it liver?
Yeah, I think it's one of the few narcotics. It's not an opiate. It's one of the few narcotics that has really a lot of side effects. Yeah. So, you know, when I say that opiates have virtually no side effects, you could take it, you know, your whole life. That excludes tramadol. Okay. So it's a weird drug, and oddly enough, the famous study out of Minneapolis by Dr. Erin Krebs, Krebs. She compared opiates with Tylenol and said that Tylenol worked as well as the opiates. Right. And then when I carefully looked at the study, she used tramadol in the Tylenol group.
So that's what they used as their other group?
They're non-opiate. And technically it is a non-opiate, but it's still a narcotic. Huh. So, and I emailed her several weeks ago, and she hasn't responded as to whether or not this was true, because maybe it was a misprint in the paper or something. So I asked her if it was true, and she hasn't responded. So I'm presuming that it is true. So she, like a lot of other doctors, believe that tramadol is not on the list of bad drugs because it's not an opiate. But then fentanyl's not an opiate either. So it's this huge difference.
Right, and they're going to be going after that soon, correct? I mean,
it's actually gabapentin or Neurontin. Apparently, what it's doing, it's one of the drugs that potentiates the effect for addicts. In other words, if an addicted person is trying to find their own medicine for their disease, and it's in short supply because the police are cracking down or whatever, then they try to find drugs that will give a boost to what they can afford.
Okay, well, so do you have to take it with the opiate? Or?
Yes, okay. You take it with the opiate.
So it's kind of like Soma, because I remember I used to have Soma, and that's what that did to me, at least.
There's all the benzodiazepines will boost the effect of the opiate, as will Phenergan, which is a drug used for nausea. Just the funny biochemistry of mixing Phenergan and the opiates, you get a boost. So a lot of street folks know about Phenergan, and they get hold of that too, and they become pretty good pharmacists, really, because they're having to buy their own treatment. See, addiction B is a disease, and it needs treatment. It needs opiate treatment, just like pain disease needs opiate treatment. We got two diseases that need the same thing, but they're not the same disease.
Well, Dr. Kline, do you have any last words for this evening? It's already an hour over.
No. I think that people speaking up and asking questions like we've heard tonight is very important, because not only can we answer questions, but that allows me to understand better what people don't know or what people are afraid of. So feel free, in any of our shows to, and that's why we made it anonymous tonight. You don't have to give your name or your area code, but you can ask any question you want. So we may do this next week. I'm not sure yet. We haven't planned the show, but I appreciate people asking, we want to hear pointed questions.
Yeah, there was a lot of questions, and I couldn't read them all because there were so many of them on YouTube tonight. But if you want to come back next Tuesday and ask, please do so. We will be here. And if there's anything ever pressing, you could also just write to me. My email's on there, or Dr. Kline's email, or Twitter, and you could ask him too. So, well, Dr. Kline, thank you so much for joining us this evening. Appreciate it.
You're welcome, and good night.
Good night. Tomorrow, Dr. Steve Henson will be our guest. He is a doctor that created Medical Missions Outreach and recently rated by the DEA and a CPP advocate. Thank you, Foundation, for joining us for another Tuesday evening at the Doctor's Corner. I'm Janelle Elgaway, signing off until tomorrow evening. Good night.
You've been listening to The Doctor's Corner with Dr. Kline and Janelle Elgaway. Copyright 2018 by EXG LLC. All rights reserved.